Hi, I'm Steve Fishbane. I am the Chief of Nephrology for Northwell Health in New York, and I'm a professor of medicine at the Zucker School of Medicine at Hofstra in Northwell. Today, I'm going to be speaking about dialysis hyperkalemia, some of what we've learned in recent years, which I think is really interesting, and then talking about the opportunities as they pertain to cardiovascular outcomes and where we may be able to do some good there. So let's start by reminding ourselves that among hemodialysis patients, hyperkalemia is a frequent occurrence. I think we're all familiar with that. This slide shows differences between different regions, and they're actually pretty significant, but where I practice in North America, the United States, hyperkalemia certainly is a common problem. Hyperkalemia associates with an increased risk of all-cause and cardiovascular mortality. So I don't think there's any controversy here that when patients have a very high potassium level, there is an immediate risk to life that's clear, important. The associations that we see in the literature between relatively lower levels of potassium, for example, in this study by Torlin et al., even levels of greater than 5.5 associated with an increased risk of death, and 5 to 5.4 an increased risk of cardiovascular mortality. My way of understanding that is that probably it's not the 5.3 potassium that gets the patient in trouble, but through the course of the study, or if you have a patient that has a 5.3 potassium level, that is a patient who, when they're having a bad weekend or they go off their diet, is the same patient who may have a 7 potassium, and thereby, yes, there may be a significant increased risk even for those patients where we measure the potassium in the 5 to 5.5 range, not expressed that day, but perhaps at another day when the potassium level is somewhat higher. Now, it's important for us to recognize, as is shown in this nice work by Blumberg, that potassium, unfortunately, although dialysis treats it effectively, bounces back quickly. And I'd like to make 2 points in this slide. First, please notice that during the dialysis treatment, the plasma potassium concentration drops very rapidly and to a substantial degree. That is concerning, and that might be related to some of the arrhythmias that our patients experience. But in addition to that, please note how the potassium level bounces back after the treatment within 1 and 6 hours as potassium comes out of cells. So the hyperkalemic patient is a patient that we're not really helping with dialysis for an extended period of time, which is why potassium binders may be important in this population. In this study by Youssef et al., we're looking at the rate of hyperkalemia. This is US RDS data, and showing that hyperkalemia is more common after the long interdialytic interval. So the Monday, Wednesday, Friday patient, you see more hyperkalemia on the Monday treatment, similarly for Tuesdays. Not surprising, so it's a longer period, 3 days without dialysis, but also it tends to be the weekend. So this is the period where the patient is with family, eating more, going out perhaps more, and with more exposure to potassium. So the LIDI, the long interdialytic interval, is one that is particularly one where we've got to be careful with patients. So our ability to treat is dialysis, it is dietary counseling, and we do have potassium binders. I don't want to speak a lot about the specific binders. We know that SPS or Kiexilate has been available for 60 years and is still fairly widely used. It does have some problems that go along with it. And newer agents, patiromer and sodium zirconium cyclosilicate, I think are both really excellent agents with similar properties for the most part. And I think probably we can speak about either of them as being just significantly preferred to SPS as a treatment. Patiromer and sodium zirconium cyclosilicate are effective and safe. They're fairly easy to use, but yes, a patient does have to take a powder in fluid, allow it to absorb, and then drink it down, has to be separate from medications. They are better tolerated and preferred compared to SPS. I think both in recent years have been shown, patiromer and SCC, to really have wonderful efficacy that's been clearly demonstrated in different populations, and to be well tolerated as well. And I find them both really to be very, very similar in terms of overall efficacy and safety. Now, in this talk, because we're talking about dialysis specifically and the Dialyze study, which is the one we're focused on, I'll be speaking more about sodium zirconium cyclosilicate, but please, I just want to make sure that people understand both of the newer drugs I have a strong preference for compared to the older SPS Kexlate drug. And I don't think that there's a preference specifically. However, in your practice, you may have for one or the other. So sodium zirconium cyclosilicate, interesting drug. It's a crystalline substance that is not a polymer, so a little bit different than what we're used to in terms of potassium binding. Very high affinity for potassium, and it exchanges sodium and hydrogen ions for potassium. But it's interesting because the hydrogen ions essentially form ammonium, get bound in the molecule, and actually have the effect of not reducing pH, but actually perhaps raising the patient's pH or serum bicarbonate concentration. And the binding to potassium, so it's an opening of 3 angstroms, which is exactly the size essentially of the potassium molecule. So it's very, very tight binding. So the cation exchangers, as discussed, are sodium and hydrogen ions. It's very high capacity to entrap monovalent cations, and very specifically for potassium, with ammonium, and that's much greater than calcium or magnesium. So this is very different than SPS, which has been used for years, because it non-specifically binds to a lot of different substances. That's different for this drug. People sometimes ask about their zirconium. In fact, in the daily diet, there's about 4 milligrams of zirconium. With this drug, the exposure is a tiny amount, so no issue, in terms of that. Here's a little bit of an example of the specificity for potassium. I'll pull your attention here. So it's called ZS9, the older name for sodium zirconium cyclosilicate. You'll see that the exchange capacity is very, very high, 2.8, 2.7, 2.6 in comparison to SPS. And this is very, very different than things like calcium, where SPS, significant binding that just doesn't exist in terms of the limits of detection, not even noticeable. So let's talk more clinically in terms of treatment. And the Dialyze study was a study that looked at the use of sodium zirconium cyclosilicate versus placebo. And this was a study done in dialysis patients. I believe the first study ever done of using a potassium binder for the treatment of hyperkalemia in people on dialysis. And It was a comparative study between sodium zirconium cyclosilicate and placebo. The drug was dosed on non-dialysis days with a goal of effectively treating the potassium into the 4 to 5 potassium range. There is a number of inclusion, exclusion criteria for those who are interested. I'll direct you to clinicaltrials.gov or to our publication in the Journal of the American Society of Nephrology. It was published in 2019. The primary endpoint was the percentage of patients that maintained the serum potassium 4 to 5 during at least 3 out of 4 dialysis treatments after the long interdialytic interval. So that Monday or Tuesday after the weekend, when hyperkalemia is at greatest risk, can you maintain the potassium in that target 4 to 5 range? Secondary endpoints measured as well. In terms of baseline characteristics, I think it's a fairly characteristic population. One thing that I always notice is that the vintage was relatively high. Patients that have been on dialysis for a while, I guess because there's less residual kidney function at that point, more hyperkalemia present because of that. But otherwise, really good matching between the placebo and the SZC, sodium zirconium cyclosilicate populations. In terms of treatment exposure, very helpful to note here that when you look at SCC, the vast majority of patients were able to be treated with either 5 milligrams on non-dialysis days, or grams, or 10 grams on non-dialysis days. 80% of patients, it's just 5 or 10 grams 4 times per week. The placebo group is in gray, obviously there because you're not getting effect. The dose driven up to 80% of patients needing 15 grams per day, but that doesn't have meaning for us. Most patients get by with lower doses. The primary efficacy endpoints, so again, pretty tough, getting patients into the 4 to 5 range in 3 out of 4 treatments in the long interdialytic interval. With SCC, it was 41% of patients versus 1%. For placebo, obviously very highly statistically significant. So the efficacy is quite good. If you widen out the range a little bit to, I think, a clinically meaningful, rather than 4 to 5 potassium, 4 to 5.5, the numbers go up substantially. Very effective medication for treating hyperkalemia in people who are on dialysis. This is what it looks like over time. So for 71 days, comparing now sodium zirconium cyclosilicate to placebo, and you see that rapidly you have a reduction in the mean serum potassium, and that stays the same until the end of study, at which point you're withdrawing and getting to about the level where the placebo group is at about a 5.8 potassium concentration. When we look at safety results, happy to note here that the drug was very well tolerated. So, I found this interesting because I had a long time interest in trying to get a study done with potassium binders in dialysis patients. I think there was concern that in this population you get a lot of adverse events, but I think you'll agree that when you compare SCC to placebo, the levels of safety here were really outstanding. Very little seen in terms of hypokalemia, same between the placebo group and SZC, maybe a tiny difference in GI disorders, but basically the drug was very, very well tolerated in this difficult population. So this was the first study that showed that SCC can be used effectively with good safety and tolerability among patients on dialysis, and that we were able to get most patients into the target range with very good effect in terms of tolerability. Now, I should note that a big question is always sodium. So there is some exchange of sodium. What happened within the study in terms of fluid accumulation? And this was looked very, very closely. So whether it was development of edema, whether it was interdialytic weight gain, whether it was by any measure we looked at, we found zero evidence of fluid accumulation, no evidence for SCC in terms of increased interdialytic weight gains. The drug was just very well tolerated, and sodium volume, not an issue. So sodium zirconium silicate is now approved for the treatment of hyperkalemia and dialysis, and is becoming pretty widely used for controlling potassium in these populations. I think this creates a couple of opportunities. One of them is our dialysis patients have a very, very tough diet that they have to follow. So can they now eat some of the healthier foods, fruits and vegetables, get some of the great effect, the antioxidants and fiber and phytonutrients that these foodstuffs have? But what about cardiovascular outcomes? So we'll recall that our population is particularly interesting in that we see a lot of arrhythmias being a cause of death in this population. 44% of deaths, arrhythmia or cardiac arrests. And that raises questions because of the linkage of potassium and rapid changes of potassium concentration to the possibility of arrhythmic death. We go back to the data of Blyer. We saw this from Foley's data, that there are more deaths, there are more sudden deaths, there are more cardiac deaths that occur after the long interdialytic interval. And that's always been very interesting. When you look at Monday, Wednesday, Friday patients, more deaths on Mondays, Tuesday, Thursday, Saturday patients, more deaths on Tuesdays. And this is highly suggestive that over the long interdialytic interval, that something is accumulating, which certainly could be potassium, but we have to, also consider volume, fluids. We have to consider uremic toxins, but certainly there's reasons to believe that potassium could be important. Here's Roy Chowdhury's beautiful study from Kidney International in 2018. So using cardiac monitors, these are implantable loop recorders, and looking at the types of arrhythmias the patients are having, I'd like to pull your attention to the much higher rates of arrhythmias that occur both during the first dialysis treatment of the week compared to other dialysis treatments. So in that first treatment of the week, whether it's rapid removal of potassium or other substances, there's a much greater risk for cardiac arrhythmias. But also you'll notice that in the 12 hours leading up to dialysis treatments, as potassium is accumulating in volume and uremic toxins, that in the period leading up to dialysis, there again is a sharp increase in the rate of arrhythmias. And that is significantly greater for the long interdialytic interval. In those 12 hours leading up to the Monday or Tuesday treatment, a very high number of arrhythmias. And this suggests both the accumulation of a substance, which could be potassium, that might be causing arrhythmias, and during the treatment, the rapid removal of a substance that could be potassium, and sets up the possibility for potassium treatment potentially improving outcomes. Again, could be volume, could be toxins. So the Dialyze Outcomes study is a study that's in progress right now, 2,300 patients. It's a global study. It's patients with a long interdialytic interval potassium of greater than 5.5 randomized either to sodium zirconium cyclosilicate versus placebo. And the primary endpoint is the time to the first occurrence of sudden cardiac death, stroke, or hospitalization and interventions due to arrhythmias. So trying to see if using a potassium binder both to reduce hyperkalemia and reduce the rapidity of drop of potassium during dialysis treatments would be effective in terms of reducing the risk for these types of events. So in conclusion, dialysis hyperkalemia treatments are advancing rapidly. I think for hyperkalemia, both patarimer and sodium zirconium cyclosilicate are very effective treatments. We have a label in the US and I believe elsewhere now for the use during dialysis of SCC for hyperkalemia. The current binders that we're using for treatment are safer and better tolerated, in my opinion, than the previously widely used SPS. But I think what's going to be really interesting going forward is to see if we can improve cardiovascular outcomes, if we could effectively treat potassium hyperkalemia and reduce the flux of potassium during dialysis treatments. Thank you for your attention.